Hello, it's my great pleasure to join you today in your meeting, Bangladesh Live. I'm really happy to be here with you. I'm just not so happy because I should have been with you in person, but for personal reasons, I cannot be there. I wish you a very successful meeting, and I'm delighted to be here again discussing a very important topic, which from a clinical perspective certainly has a lot of impact in our daily practice. I'm going to talk about chronic coronary syndromes, an update on the medical management of this clinical condition. This is my hospital here in Lisbon, Portugal. We always enjoy having colleagues coming from other parts of the world to be with us, and I hope colleagues from Bangladesh can join us soon. Well, I'm going to talk about chronic coronary syndrome, which usually means stable angina, which is sometimes a little bit neglected, or at least not so well understood and taken into account in many parts of the globe. And we know today that stable angina can affect approximately over 110 million people globally. There is some variation across the world, but overall, these are the figures. And we know also data coming from different sources, and this is data coming from a survey over 1,600 patients, outpatients, and it showed that about 1 out of 5 primary care patients with chronic coronary syndrome, they have angina. About 20% have angina at least once monthly, about 12.5 daily or weekly, and 8.7 monthly angina symptoms. If we look at recent data coming from the US, looking at the prevalence of chronic heart disease, we can see there is also a relation with age. And if we look at the gender distribution, we can see that after 60 years old, there is a prevalence of males over females, but still quite relevant for both genders. Very importantly, the fact that the patients have angina, that's associated with a greater physical limitation and poorer quality of life. We can see here a relation between the frequency of anginal episodes and the impact on physical limitation in blue and quality of life in yellow. You can see a significant decrease the more frequent the angina episodes are. Also, data from the REACH registry, probably one of the largest registries for patients with coronary disease, it shows that angina symptoms can actually be associated with increased risk for adverse cardiovascular outcomes. And we can see here that after 4 years of follow-up of these patients, the event rate was much higher in patients who had stable angina than in patients with no stable angina. One important aspect in these patients is the fact that about half of the patients with frequent angina are on suboptimal anti-anginal therapy. We can see here these recent data showing that either 5 and about 40% of the patients are either on no or just one anti-anginal medications. And this shows again that a significant number of these patients are on suboptimal anti-anginal therapy. In 2019, there were some guidelines that were produced by the ESC, and in 2023, ACC and AHA, they also produced guidelines for the management of patients with chronic coronary disease or chronic coronary syndrome, as we say in Europe. And let me just highlight some of the aspects that these guidelines provide to the management of these patients. Well, first of all, the recognition that if you look at the natural history of chronic coronary syndromes, we have time on the x-axis, and here we have the cardiac risk. We can see that the patients at higher risk are the ones who have insufficiently controlled the risk factors. They have suboptimal lifestyle modifications and or medical therapy, and they have large areas at risk of myocardial ischemia. If we can actually improve the control of risk factors, implement lifestyle changes, have adequate therapy for secondary prevention like aspirin, statins, or ACE inhibitors, and when needed, appropriate revascularization, we have a very significant impact on reducing the outcome, on improving the outcome and reducing the risk of these patients in the long term. Now, these are the different steps coming from the ESC guidelines in patients with angina and/or dyspnea. Dyspnea was included in these guidelines as an equivalent of angina. And this is the diagnostic approach: assessing symptoms, consider comorbidities, look at the resting ECG, at biochemistry, chest X-ray, echo at rest, and assess the pretest probability and clinical likelihood of coronary disease. And then, based on sex, age, and nature of symptoms, we can actually have a pretest likelihood of the patient having coronary disease. Of course, there is a decreased likelihood if the patient has normal ECG or has no coronary calcium on the CT calcium scoring system. There is an increased likelihood if the patient has several risk factors for cardiovascular disease, if there are resting ECG changes, left ventricular dysfunction, abnormal exercise ECG, or evidence of coronary calcium by CT. And in this case, we can see here, if looking at the clinical likelihood of obstructive coronary disease, increasing from left to right, patients who have a very low clinical likelihood. In these patients, probably no diagnostic testing is mandated. But if there is intermediate likelihood, these are the patients who may be good candidates for coronary CT angio or even testing for ischemia. And then in a very high, at the end of a very high likelihood, these are the patients who may undergo immediately invasive angiography. And this is actually the algorithm with 3 different entrances according with the characteristics of the patients, either for coronary CT angio, for non-invasive testing for ischemia, or for invasive coronary angiography. And again, these diagnostic pathways are based on the clinical likelihood and the patient characteristics. And all of these will imply, looking at that, will imply if the patient has major indication, again, for coronary CT angio, for non-invasive ischemia test, or for going directly to invasive coronary angiography if it's a patient with high clinical likelihood or typical angina. And again, if we look here, we can see that coronary CT angio should be considered as an alternative to invasive angiography if another non-invasive test is equivocal or non-diagnostic. And here we can see that the decision tree for patients undergoing invasive coronary angiography, where we can see that if the patient has documented ischemia, multivessel disease with lesions with FFR less than 0.80 or IFR less than 0.89, these are the patients who should be considered for revascularization on top of medical therapy. And again, here you can see the algorithm by using this assessment, how to identify the patients that may benefit of revascularization. If you look at the ACC/AHA guidelines, they're not so much different. So basically, for recommendations for diagnostic evaluation, again, a class 1 indication in patients with chronic disease and change in symptoms or functional capacity, the use of an imaging method to assess ischemia, and in patients with change of symptoms or functional capacity that persist despite guideline-directed medical therapy, invasive coronary angiography is recommended for guiding therapeutic decision-making. And here, for risk stratification and prognosis, the indication is to do risk stratification, incorporating all the available information, including non-invasive or invasive or both cardiovascular tests. And in terms of treatment, it's a class 1 recommendation that patients with chronic coronary disease, optimization of guideline-directed medical therapy is a must. So medical therapy is a must in these patients. Patients who have newly reduced left ventricular systolic function or clinical heart failure or both, in this case, coronary angiography is indicated to assess coronary anatomy and decide on potential revascularization. The goals of revascularization in patients with chronic coronary disease who have lifestyle-limiting angina despite guideline-directed medical therapy with significant coronary artery stenosis that are amenable to revascularization, then revascularization is recommended to improve symptoms. And in patients who have significant left main or multivessel disease with severe dysfunction, ejection fraction less than 35%, CABG, in addition to medical therapy, is a recommended indication of revascularization for these patients. And these are, again, recommendations which actually are very similar between the European and the American guidelines. Again, in terms of decision-making for revascularization, patients who have angina or angina equivalent, no previous evaluation for ischemia, and with angiographically intermediate stenosis, the use of FFR or other proven non-hyperemic pressure ratios is recommended, and this has a high economic value intervention. And of course, the heart team approach should be implemented for discussing particularly of the more complex patients. If you look specifically at the treatment of these patients, the medical treatment with symptomatic angina, we have two big classes of patients. We have the patients who have a hemodynamic impact by either increasing oxygen supply or reducing oxygen demand, and the metabolic agents that protect cardiomyocytes from ischemia. And finally, here we have the central figure, which basically shows a very important aspect, the relation between the patient, the clinical care team, and the shared decision-making, looking at risk, looking at the symptoms, the patient preferences and attitudes toward risk, and then looking at different treatment options, looking at risks and benefits that will prevail on the choice that should be made together in a shared decision-making with the patient. So in conclusion, we have new definition of stable coronary heart disease. In Europe, we call it chronic coronary syndrome. There's been an updated and improved data on the prevalence of coronary disease, including dyspnea now as a symptom and as an equivalent of angina. There's now a more prominent role of coronary CT angiography in excluding significant coronary disease in patients who have a low clinical likelihood, provide optimal medical therapy, and finally, revascularize when indicated for symptom relief and improve prognosis. And with this, I finish my presentation. Again, thanking you so much for this kind invitation. I hope next time I'll be able to join you in Bangladesh and have a very successful meeting. Thank you so much. Bye-bye.